Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with non-cardiac thoracic surgery? Find out more right now. My guest this evening is Dr. Puja Khaitan, a noted thoracic surgeon practicing in the National Capital area. Dr. Khaitan, welcome to Housecall.
Thank you. Thank you for having me. It was a pleasure being here.
My pleasure. Briefly tell our viewers about your professional background.
So I'm a thoracic surgeon. Basically, I'm trained in cardiothoracic surgery, but I choose not to do cardiac surgery per se. So I operate in the thoracic cavity that's essentially anything above the diaphragm. Although some of our surgical treatments does include things that are right at the level of the diaphragm, which I'll discuss in further detail as we go along, I'm sure. I did my training, I did my med school at UT Southwestern in Dallas, Texas, and then I moved up north from there to go to Emory for general surgery residency, and then I did my cardiothoracic fellowship at Brigham and Women's. I did do a 2-year research fellowship at MD Anderson. And then I practiced in Houston for 4 years before moving to Washington, D.C. in 2017.
And where do you currently practice?
So I'm currently affiliated with several Medstar hospitals. I currently am 100, for the most part at Washington Hospital Center, but then I cover Georgetown University Hospital, Triple MC, which is the Montgomery Medical Center, as well as Southern Maryland.
Great. Well, let's go on then to discuss the topic at hand, which is non-cardiac thoracic surgery. And there are many aspects of what you do that I want to cover this evening. For example, let's discuss a very common issue that I, as a gastroenterologist, deal with each and every day, and that's reflux esophagitis, the medical term for heartburn. Now, most of our viewers are aware that the large majority of these patients are successfully managed medically. However, a subset of patients may require something above and beyond medical intervention. Dr. Khaitan, tell our viewers briefly, at what point do we consider surgical intervention?
So that's a very good question. Unfortunately, the true incidence of patients who have Gerd and who are suffering from it is difficult to say, only because so many of these patients will take over-the-counter medications. And so we only see, like you said, a subset of patients who are not self-medicating with medications for their long-standing reflux. And only about 30 to 40% of those patients, which is sort of a decent fraction of patients, will fail medical management. No proton pump inhibitor will actually treat their symptoms. And at that point, it's usually recommended that they undergo some sort of surgical evaluation to see if their lower esophageal sphincter, which is loose, and that's the essential problem in these patients, if that can be tightened with a surgical procedure.
What then are some of the surgical approaches to patients with heartburn, reflux esophagitis, that don't respond to medical therapy?
So the traditional modalities used to be laparoscopic, which is either using camera and going into the abdomen, or open fundoplications. And fundoplications are essentially wraps where you take the stomach and you wrap that around the esophagus so that the stomach can't so that the esophagus and stomach can't ride back up in the chest through the diaphragm. The reason most commonly that this occurs, where the lower esophageal sphincter is loose, is the diaphragm opening where the esophagus passes through to go into the abdomen is rather lax and loose. And essentially what we do in that operation is we tighten it with some stitches to close them up together. Now, in the last decade or so, a lot of endoscopic interventions have come to play. And there are other modalities where gastroenterologists or interventional gastroenterologists will go in and plicate the redundant stomach and actually clip it so that you don't have this hernia and the things don't ride back up in order to make it a competent lower esophageal sphincter.
What is the safety of surgical approaches for reflux esophagitis in terms of any adverse outcomes, and how durable is the benefit when it works?
So unfortunately, both have endoscopic as well as surgical approaches have their pitfalls. And one of the things with surgical fundoplications is that we warn patients that there's a good 20 to 30% of chance that you may have a recurrence over the next 10 years. In addition to the complications of any surgical procedure where you have general anesthesia, you go into a patient's abdomen, you may have some other injury that you may not anticipate, and the patient may have a prolonged hospital course. The benefit of it are wide as well. One problem with this antacid reflux medications that patients take is that what they essentially do is they make your acidic environment more alkali. And we all know alkali is more caustic, and so you may have a mechanical defect of your lower esophageal sphincter, but you're still bathing your esophagus in these gastric contents, which are now alkali, and indeed that may be causing more of a caustic injury. The advantage to fundoplication is that it actually takes that mechanical component out of the question. So the chance of you at least having this constant bathing and inflammation of the esophagus is taken out. There are some comparable and controversial literature which says that endoscopic fundoplications are equivalent, if not better or worse, compared to fundoplication. So only time will tell whether or not one is better than the other.
What exactly is the Stretta procedure?
So endoscopic procedures do include a wide variety of procedures. A Stretta is a radiofrequency ablation. And essentially what an interventionalist does is they go in and they ablate the inside of the esophagus, sort of the distal end of the esophagus, which is a very terminal aspect right before it goes into the stomach. And basically what that does is because of the circumferential burning, it causes scarring, and that can prevent ongoing reflux. And that's the concept behind the Stretta procedure.
There's also a new procedure called the Linx Magnetic procedure. Would you share with our viewers what exactly that entails?
Right. So Linx procedure is basically a magnetic sphincter augmentation. You can think of these as interlinked beads. They're essentially titanium beads where you can it's unfortunately or fortunately, it's done laparoscopically, so you do have to undergo general anesthesia. You undergo a surgery, you go into the abdomen, and you actually place this ring of beads around the hiatus, which is essentially where the esophagus meets the stomach, so that you can tighten it. Now, as a food bolus passes down a person's esophagus and they hit this Linx device, it tends to open up so that it can allow the bolus to pass. And as soon as that passes, it tightens back again with that magnetic force, thus allowing you to have somewhat of a competent sphincter. The only issue with this is that you should rather not have a large Heidel hernia, so you can't have a large defect with this. The advantage to this procedure is when we do our fundoplications, you actually do enough dissection around the stomach to create the wrap where the stomach goes behind the esophagus to create the sausage wrap. You don't have to do that with the Linx procedure. So you avoid all these disturbances to a normal patient's anatomy. So it allows you to keep the anatomy. But obviously, if a person has a large paraesophageal hernia where most of the stomach resides in the chest, the Linx procedure won't work because you have to somehow reduce all the contents back into the abdomen and then do some sort of application or wrap, and the Linx device won't hold after having done that.
So if somebody has normal anatomy, no significant hiatal hernia, do you favor the Linx Magnetic procedure over a fundoplication at this point?
I've heard from other surgery colleagues. I personally have not been trained in the Linx procedure and hope to one day start doing them. But from my other surgical colleagues, they truly enjoy it. It's a very short case. The patients have good operative outcomes. The surgeons say that they have equivalent outcomes as far as the open fundoplication, the entire fundoplication where they have to do the entire dissection. And The only complication that everybody fears is whether or not these metallic beads can erode, although that literature is quite scarce.
Very good. You've mentioned several times hiatal hernia. Please define that for our viewers.
So a normal anatomy includes, when you have your mouth goes into the esophagus that travels the cavity in the chest, and at the level of your diaphragm, you go through that opening, and the esophagus then turns into the stomach and the abdomen. When that little opening in the diaphragm, which is called the hiatus, when that gets dilated and bigger over a lifetime, as we all gain more weight, as our tissue become weak, women become multiparous, and that tissue laxes, the stomach can actually ride through that opening in the hiatus and to actually go into the chest, such that the majority of the stomach starts to reside in the chest. And that itself predisposes a person to chronic reflux, because now their stomach is predisposed to the negative intrathoracic pressures instead of staying into the abdomen, where you don't have the negative pressure of having reflux contents back into the esophagus.
Do you commonly find that hiatal hernia, if it gets big enough, does require surgical intervention?
So at this point, in this day and age, we do recommend that if a patient gets diagnosed with paraesophageal hernia, and if they're an operative candidate, meaning that they don't have any other surgical contraindications, that they should undergo some sort of a reduction of that paraesophageal hernia, because over a lifetime, if you speak with these patients, you can almost tease some symptoms out of them. They've been living with either reflux or regurgitation, where the food contents keep coming back soon after they've eaten, or they'll admit that, yes, they can't eat everything, bread gets stuck or lettuce gets stuck. Although if you ask, all the patients at any point in time, they may say, I don't have any symptoms and I'm okay with living with them, with the symptoms. Now, obviously, if you're 89 or 90-year-old and you get diagnosed with a paraesophageal hernia at that age, it's questionable whether or not you need that repaired. But if you're young, in your 40s, 50s, or 60s, you have a long lifespan ahead of you. So we recommend surgical repair.
We have 1 minute left. Clarify for the viewers the difference between hiatal hernia and paraesophageal hernia. We have 1 minute.
So you have if you have a small hernia where you have a small defect, your stomach can go up and down, what's called sliding hiatal hernia. And that's not a big consequential deficit. You could live and die with it. But when you have a large hernia where your entire stomach is sitting in the chest, that has long-term consequences. So at that point, we recommend surgical repair.
Very good. We'll be back in a moment with Dr. Khaitan discussing non-cardiac thoracic surgery. We'll be right back.
We know that we're asking Americans to do a lot right now. So we're asking everyone to be selfless for others so that we can protect those who are most susceptible to this virus.
A question I often get asked is, why should young people care about the spread of coronavirus? Well, we know that people with underlying medical conditions over the age of 60 are at highest risk, but they've got to get it from somebody.
Social distancing is really physical separation of people.
It's what we refer to when we ask people to stay at least 6 feet apart.
Not going to bars, not going to restaurants, not going to theaters where there are a lot of people. It all just means physical separation so that you have a space between you and others who might actually be infected or infect you.
We all have a role to play in preventing person-to-person spread of this disease, which can be deadly for vulnerable groups. For more information on how you can social distance, please go to coronavirus.gov.
We're back. My guest this evening is Dr. Puja Khaitan, a noted surgical authority on non-cardiac thoracic surgery. Dr. Khaitan, when we paused for the break, we were discussing surgical approaches to reflux esophagitis. Let's now go on to discuss a complication of heartburn, and that is something called Barrett's esophagus. Explain to our viewers what exactly is Barrett's esophagus.
So absolutely right. Long-standing acid reflux can lead to a sequelae called Barrett's. And essentially what it is, our esophagus is covered with a squamous epithelium, which are these light, flat line cells. And when they undergo inflammation because of this constant injury from the acid from the stomach, they can undergo changes, and they can change from a squamous epithelium to columnar epithelium, which is true of the gastric or the stomach wall. And that process is called metaplasia. And that process, unfortunately, keeps, because of chronic reflux and chronic bathing and insults and inflammation, can continue to undergo change and then turn into eventually cancer. However, there are gradations. Starting from this metaplasia or Barrett's esophagus, you first undergo low-grade dysplasia, then to high-grade dysplasia. And if not monitored and not caught in time and not treated with appropriate anti-reflux therapy or a fundoplication or wrap, some sort of a procedure, that can eventually lead to esophageal cancer.
Now, I, of course, as a gastroenterologist, see patients with Barrett's each and every day, and we monitor our patients. The standard of care is to do an endoscopy every 3 years. Once, of course, the Barrett's has progressed to dysplasia, a potential precancerous lesion, that's when the consensus is that some sort of intervention is required. So what sort of intervention do you offer, both non-invasive and surgically, to treat Barrett's esophagus with potential precancerous changes?
So there are multiple ways to treat Barrett's. They are, in the sake of time, many strategies have come and they have not stood the test of time. And at this time, the most common practices that we use is either radiofrequency ablation or cryotherapy. What the purpose of that is that it goes into the esophagus and endoscopically you ablate this mucosal lining, this inner lining of the esophagus, which could have been insulted from the inflammation. And that can at least kill these precancerous cells so they don't progress onto cancer. You must complement that with some sort of an anti-reflux treatment, either medical or surgical, in order to have successful outcome. And as far as monitoring purposes, there are multiple guidelines from different societies on how soon should you surveil these patients. They should get routine endoscopies with biopsies every 1 to 2 centimeters that are in 4 quadrants. And you monitor them to make sure that the dysplasia is resolving with your appropriate treatment intervention and not progressing. If it is progressing, then their symptoms are not well controlled and they need further workup and intervention.
If somebody, unfortunately, has not sought medical attention and they've been self-medicating the heartburn for years, as we unfortunately have all experienced as physicians, some patients unfortunately present first with their esophageal cancer. What kind of symptoms can a patient present with who has progressed to esophageal cancer?
So some of the most common symptoms that we encounter that patients are being diagnosed with esophageal cancer is dysphagia. In other layman terms, that's inability to swallow. Patients will quite often come and say that when we swallow such and such things, they get stuck in either the middle of their chest or low in their chest. Sometimes patients will even say it's high up in the neck. And I think that's more of a globus sensation, just depending on where their lesion is and where their esophagus gets obstructed at what level. They can have symptoms of regurgitation, and regurgitation and reflux are 2 different terms. When we talk about regurgitation, we're talking about undigested food that comes up. And so you may have swallowed a piece of bread and choked on it, and then you had to go throw up and in the sink, in the kitchen sink, and bring up that piece of bread. So that's regurgitation, and that's because of pure obstruction. The other symptoms that people can present with is weight loss. And that's very common. Patients, that's true of any cancer for the broader picture, but for esophageal cancer, that's a common way of presenting, where a patient doesn't realize that they've been losing weight because they're unable to eat and keep enough of their calories down.
What are some of the approaches you can offer a patient who has diagnosed esophageal cancer?
So if you're lucky and you get diagnosed, on your screening endoscopy, if you get diagnosed with a nodularity and your gastroenterologist scopes you and finds this lesion and plucks it and sends it off and finds out that this is invasive cancer, you could undergo an endoscopic resection if you're an early stage lesion. And those modalities will at least salvage your esophagus, and you may not have to undergo a esophagectomy, which is a morbid procedure in itself. something I love, but something I don't recommend unless you really need to undergo. As a director of esophageal surgery, I routinely perform robotic and minimally invasive esophageal surgeries. And what that entails is that if you've got a deeper tumor that's more than the superficial lesion, we then consider you for a surgical resection where you take away 80 to 90% of your esophagus, make a tube out of your stomach, and then pull your stomach up in the chest and connect that in the neck so that you can have reestablished your continuity. Now, there are sort of multiple caveats in that regimen. There's something called trimodality therapy. So a patient who gets diagnosed with advanced local regional cancer, they should be treated with chemotherapy and radiation up front prior to undergoing surgical resection. And then the greatest fear is that you get diagnosed with stage 4 disease, which is disease outside the esophagus, which may have metastasized to your liver, lungs, bone, brain, and then that's stage 4, and there's no role for surgery at that point. At that point, we recommend palliative chemotherapy to control your symptoms and give you some quality of life.
Let's go on to discuss then another important topic, which is a Zenker's diverticulum. What exactly is that?
So diverticulum are basically outpouchings. You can have outpouchings in anywhere in your GI tract. In the esophagus, there are the two most common diverticulum that we discuss is up at the level of your neck, which is the Zenker's diverticulum, and one that's right above the level of the diaphragm, the epiphrenic diverticulum. And in addition to these, there are other diverticulum that can happen where your esophagus can pouch out because of some sort of an inflammatory reaction from what we call the mediastinum, which is the area that resides in between your two pleural cavities, in between your two lung spaces. People who've had incidences of prior fungal infections, be it TB, histoplasmosis, they can have these fibrotic reactions in their chest, and they can have these outpouchings where the esophagus pouches out and causes the diverticulum. Those are called true diverticulum, and they're usually, for the most part, inconsequential. Patients can live with them, they don't cause a problem. But if you've got a false diverticulum, such as a Zenker's on an epiphrenic right at the diaphragm, what happens, your inner lining of the esophagus actually herniates through a defect of muscles, where your muscles separate, and then the mucosa, the inner lining, causes this diverticulum, and it's an outpouching in your neck. These patients will commonly present with halitosis, which is foul smell. So if you have a family member who has a very foul smell, you should recommend them that they may need to go see a gastroenterologist and get further worked up to make sure that that's not what they have. They'll also complain of food, a bolus sensation, where a globus sensation is the word, where the food bolus gets stuck in the back of their throat and they feel like they can't get that down. And they have to sometimes chug a gulp of water to get it down.
How is this sort of outpouching repaired?
There are two main approaches, like we were talking about earlier. There's an endoscopic approach, and then there's an open neck approach. The endoscopic approach, it can be done by either the GI docs or the thoracic surgeons, or even the ENT surgeons. And essentially what that entails is there's a special retractor that goes into a person's mouth, into their neck, down their esophagus, and because it's so high up in the neck, the scope can reach there, and you grab the common wall between the diverticulum and the esophagus, and you actually divide that so that that common wall gets dissolved, and then the whole diverticulum as well as the esophagus becomes one common lumen or one common channel. The other approach is an open approach, and I truly like these operations. They're so nice and cute when you operate them on them. You actually go into the neck, usually for the left side, and you make an incision, and you go find the esophagus, and usually these diverticulums are tucked behind the esophagus. So you dissect it out, and then you divide them flush with the esophagus. In a open surgical approach, you actually get rid of the entire diverticulum. If they're extremely small and you can't divide them, you can tether them to the back of your spinal muscles so that they remain anti-gravity and things don't get stuck in them when the patient is swallowing food, so that they don't cause a problem. The other problem with these things are there's usually a muscle that's further down that's causing the obstruction, that's causing this mucosa outpouching. It's called the cricopharyngeus in the neck. And that needs to be further divided in order for you to not have a recurrent diverticulum form.
Which procedure do you prefer, the endoscopic approach or the open approach?
I do them both. The important part with the endoscopic approach is that the patient's neck can't be very stiff. They should be able to hyperextend their neck, because when you're doing this procedure, you pretty much hang them backwards. But if a patient has had a carotid endarterectomy, which is a neck procedure in their carotids, then usually I won't operate to the neck. So you just weigh the risk and the benefits for each case. I prefer the open approach just because I like operating. I'm a surgeon, so I prefer that approach over endoscopy. But I think both have their own benefits.
We have 1 minute left. Briefly, what exactly is achalasia?
So achalasia is another condition, and that can lead to epiphrenic diverticulum, the other diverticulum I was discussing. And that's the tightening of the lower esophageal sphincter. It's the complete opposite of gastroesophageal reflux. So that's where the lower esophageal sphincter is too competent, and the circular muscle fibers are so tightened that they cause an obstruction to esophagus contents. And so in that case, while you address the diverticulum, much like Zenker's, and you divide that flush with the esophagus and remove it, you have to address by opening up the muscle. And so you essentially go in laparoscopically. It can also be done endoscopically, and you divide this muscle so your esophagus can then open back up and allow all the food contents to go into the stomach.
Dr. Khaitan, thank you for joining us on Housecall. If our viewers have any questions, how can they reach you?
Please call my office, 202-877-8115. 202-877-8115. This felt really short. We must do this again.
We've enjoyed your information. Thank you for joining us on Housecall.
Thank you, Dr. Doman.
My thanks to Dr. Khaitan for an excellent interview. My thanks to my team at the studio for making this show work so well. And my thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a fascinating program. My guest will be an infectious disease specialist from Vancouver, Canada, and we'll be comparing and contrasting the Canadian approach to COVID-19 with the United States. It should be a fascinating show. See you then next time for another edition of Housecall. Good evening.